Hi, I'm Ragini Sanyal, a clinical research manager with Qbtech, and we're here today to discuss medication management and titration using objective measures. Today I'm joined with Dr. David Aversa and Dr. James Wiley. Thank you so much for joining us. If you don't mind telling a little bit about yourself.
Okay. Hi, my name is Dr. David Aversa. I am a board certified general psychiatrist, a child and adolescent psychiatrist, and a forensic psychiatrist. I treat adult kids and families in private practice. I've worked in many different settings, inpatient to in-home services, and I do lots of evaluations for courts and schools, and a lot of consultation to and second opinion evaluations.
Okay, great.
And I'm Dr. James Wiley. I'm a pediatrician, a patient with ADHD, and the parent of 2 kids with ADHD. My background is actually in chronic disease management in children. And almost 20 years ago, I stopped seeing kids for those reasons and devoted my practice to kids with learning and attention problems, and founded FocusMD, which is a network of practices dedicated to kids like mine.
Okay, thank you so much for joining us. So let's talk about medication management in ADHD. What are your thoughts on how we use objective measures for that?
Well, you know, it's always a question. We know from the MTA study from 1999 that medication effectiveness is dose related. So finding the right dose of the right medicine is the key in managing ADHD. But how do you get to the right dose? If you have a hard time getting feedback sometimes. In the clinical situation in clinic, you often have parents or grandparents that don't see the child during the bulk of medication effect, but a couple of days a week. Sometimes you can get teacher rating scales, but having an objective measure that is standardized can be extremely helpful in optimizing dose of medication.
Yeah, and I add to that. I mean, there's a lot of different medications, even within the same type, and what you don't really know is which is going to be the effective medication for that person and the effective dose. And, you know, a good practitioner will always start at a lower dose.
Yes.
And, you know, and titrate up appropriately. And we always say start low and go slow, but do go. And for stimulants, the good thing about them is you know very quickly how well that dose works for you. So you don't have to wait weeks to months before you go up on it. And I tell all my patients that don't be shocked if a low dose works, but don't be bummed if the low dose doesn't work. It's just a low dose. Have some patience,
great to keep in mind.
And we're going to get there together. And, you know, I think, and then to the point is, when is it enough? And I think that's where you can add your objective measures before you start, and then after to see, has there been enough change to say we're where we want to be at this point?
And, you know, with regard to parents being part, because as a pediatrician, the parents are almost uniformly afraid of these medicines with good reason, because they were misused to sit little boys still and quiet when back in the days of Adderall and Ritalin.
Yeah.
And so they have justifiable concerns about dose of medication. But the bottom line is, even in children, the dose is not determined by age or size, weight, severity of symptoms, what the testing shows, what Dr. Wiley thinks. It's definitely based on that individual's metabolism of that molecule, that particular medication, and the time release formulation, how the medicine goes into the bloodstream. And different kids and adults metabolize at different rates. And that's why it's so very specific to each individual.
Yeah, and how long it's in the effective zone. Like
Absolutely.
There's this medication's going to last me 12 hours. I said, well, that dose might not, because it only in the effective zone for a little bit, because that's not the right dose. And they're always looking for like those kind of answers. And you say, well, we have to wait and see.
Yeah.
And, you know, and the other thing I always reassure them about is like, you know, because sometimes there are side effects. If there's something we really don't like and we can't get past, we stop the medication. And by the end of the day, the kid is back to where they were before. So, and I say that's how quickly they'll rebound. And I think that reassures a lot of parents about it. And, you know, I think it will ultimately help them, and you try to partner with them and the kid. And if it's the adult, with the adult, about we're a team, we're going to do this together. We want to eliminate the difficult things so you can be more of you and not, not like a limited version of yourself.
No parent wants a robotic zombie version of their child to replace their ADHD behaving child. So the key is to assure the parent that that's not what we're trying to do.
You're not changing the child, but helping them to be the best version of themselves.
Treating the medical condition and leaving the child alone is a phrase that I use a lot. No zombies. So if your child becomes flat or has other significant side effects, like a significant decrease in appetite or and others, then that's too much medicine. I find, and David, I'm interested in how you approach this, but there are three things that I tell parents to look out for because every parent is concerned about over medication, right? But the studies show that most kids don't have enough medicine, especially in a community medical setting. So there are three indications that it's not enough medicine, at least three. It's just not effective enough. The teacher and the parent are not noticing that the symptoms are well controlled. It's effective for a number of hours, as David was saying, but at the afternoon, it loses effect before an 8-hour window if it's an extended release medicine, and especially if that loss of symptom control is associated with a rebound, either emotional reaction or irritable reaction, sort of what we call the crash. And the analogy I use is you cleared the tree line, but as the medicine was being metabolized out of the system, you hit a power line on the way down. And parents really resonate with that because that is what it feels like to them. And very often, if they're not having morning blunting, going up on the dose will lead to a safer landing. Is that your experience as well?
Yeah, I mean, definitely. And I think, back to it, like, we don't want to create little zombies. We don't want these little, and sometimes it's, again, that specific formulation of that specific medication.
Exactly.
And you have other choices, and it's just we're not there yet where I can do a mouth swab in my clinic and get some genetic information saying, oh, this is going to be a kid that will respond to Concerta in this range, and people will say, then aren't you treating your kid like a guinea pig? And the answer is no, because we know the medication works. I just don't know what dose it's going to work yet. And there are times you got to try more than one, and that's sometimes hard for parents, and it's frustrating because I want to make them better the first time.
And it would be the same. My background is in chronic disease management. I only came to ADHD management in the second half of my career. And I tell parents all the time, this is like starting insulin in a new diabetic. I know generally that insulin will help and how long the different formulations are supposed to last. But finding a regimen that gets the blood sugar normal all day and all night is a challenge. And you have to be aware that there are probably going to be some low blood sugars. So there are going to be some days with side effects as we optimize the medication. But the long-term benefit of medication management is so extraordinary that it's worth those frustrations that David is talking about.
So these sound like some of the challenges you guys face while trying to titrate ADHD, right? Making sure you find the right dosage that the patient's responsive to without feeling the frustrations of the crash or overcorrecting where they're getting a flat affect.
And if they're having side effects, they're usually front-loaded on the first couple of days of medication. So we do tend to say, stick with it unless it's really significant, the side effects. Stick with it for 3 to 5 days, or maybe even a week, because side effects do tend to go down with time.
I actually recently started calling them adjustment effects.
Adjustment effects is a great word.
Because a side effect is persistent. And I always say, like, I can't guarantee you not something that's going to happen or that there's going to be a side effect. And I always say, like, if you give them the kid the medication, and let's just say there was an underlying anxiety disorder, and an hour later they're off the chart, that's pretty likely that the medication is stimulating the anxiety. Whereas if that happens, like you said, at the end of the day, well, that's the crash. So actually, they don't have enough of it. So that's where the art comes in, and I think that's where. And there are some kids that you can give a long acting in the morning, but every time you try to go up on that long acting, it's a little much, and then you got to be flexible. Like, okay, then I can give a short acting booster in the afternoon just to carry them a little longer, and that's where you have to be flexible. You're treating the person. You're not treating a study. You're not. And every kid's different, and it makes it hard for us because I can have 100 kids with ADHD, and they might all have different. Like most of them probably won't have the exact same regimen.
Yeah.
We often hear from parents, my friend's child did well on this medicine, or my nephew did well on this medicine. And it's you have to be kind of creative to find a way to say that's wonderful. It has nothing to do with your child whatsoever.
Yes.
Even a brother and sister might be in the same gene pool, but at opposite ends.
Right. So you have to really treat that specific case of ADHD, that specific person who's whatever their background, their symptom, their even subtype, right, of ADHD as well. Any other major challenges that you guys seem to face when trying to titrate your patients?
I think that there's two main ones that first is time. I mean, parents are busier than ever. And, more often you have if you're lucky, you still have, you have two parents that are working. They're busier than ever. Kids are busier than ever. And there are a lot of other obstacles, like there are things in their lives that could be like psychosocial stressors. And practitioners are busy. And sometimes, when you're looking at your schedule and you don't have a lot of time slot, and then they're comparing it to their life, and it's sort of like, it's not messing up. And that's sort of sometimes the biggest challenge is because we got to get together soon. Like none of us want to wait a month before we see them. I want to see the kid in the next 1 or 2 weeks. So that's a challenge. And the next challenge is that there's a supply chain shortage. It's harder than ever to prescribe stimulants. You electronically send it to a pharmacy, and then the patient goes to pick it up, and the pharmacist says we're out, and then they have to call us, and then we call other pharmacies, see if you actually have it. Then we have to resend the prescription, and that could take time. And in rare cases, you have to actually change from one medication to another, and that's another conversation because maybe it's the same or really similar, but you still want to have a conversation how they're a little bit different. Right. And to me, that's the biggest barrier to getting kids effectively and timely treated is the time, because we all have really busy, chaotic lives. And then when you're doing your job and it's not anyone's fault other than there's just not enough of that medication or that pharmacy doesn't have it. And I don't know about you, I spend every day of my life, a portion of my life is redoing a prescription because it wasn't available, and that's a lot of burden on the patients, and they sometimes delay in care, and then for us because we're redoing our work, and I didn't do it wrong the first time. It's just unfortunately there wasn't there in that specific pharmacy.
And you add to that insurance coverage, so sometimes it's not clear what the patient's insurance will cover. And that's a real barrier to parents being able to in addition to the supply chain issue, is that we might prescribe a medicine that looks like it should be covered, and it might require prior authorization, or that may not be covered at all by their insurance. So that's another problem. I would add to the folks that are busy that David has so correctly pointed out. One of the best measures of medication titration effectiveness is a teacher rating scale, that the teacher rates specific ADHD behaviors during the school day. And although we advocate for 7 days a week medicine, because ADHD is a medical problem at the end of the day, not a school problem. And the home issues with redirection and correction lead to its own set of problems. But one of the best indicators of good medication management is what is this teacher seeing in the classroom. And so often, but teachers are very busy too. And so many of them go the extra mile and update us, but it can be a challenge to get that information to the clinician.
Absolutely. And I mean, you're trying to base your best judgment on whether they're optimized or not. Are they progressing the way they should be based on this feedback you're getting from teachers, from parents? So how would objective measurements help aid in this
I'll give you one. I was thinking of another challenge, and that is, let's say we're seeing a patient. Now, we're in the middle of the school year, right? But let's say we're seeing a patient at the end of May, early June, and he's just failed third grade. Or as one of my patients said last week, I redshirted third grade. Now now I'm going to try to titrate medication, right? But I don't have any information, no input from the school or anything. And so maybe he's in day camp and the parents are both working, or so it can be hard to assess focus. And so that's when objective testing becomes, that's an example of objective testing being just absolutely essential. The other is measuring school performance by itself, even with the teacher rating scale, is not going to be without its problems, because there can be other reasons for inattention. Mm-hmm. The kid could be being bullied, or may have dyslexia or learning disorder, or may have other issues going on besides ADHD that are affecting classroom behavior or focus. Mm-hmm. So objective testing can help clarify, okay, so he's not paying attention in the classroom, but that could be because of a learning disability or something that's tagging along with the ADHD.
Mm-hmm.
And I would say, back to the sort of helping decrease barrier, because if you do need a prior authorization and you have something like a QB test, you have an objective score that they can't argue with. So you're like, look at this kid is in the 99th percentile for inattention, 98th percentile for hyperactivity, 98th for, their symptoms are high. We have this test, and it helps. And back to the insurance. The other difficult thing about insurance is people change all the time because it's employer based. I think that's one of the worst things that happen, and people don't understand that just because you're on it, you have insurance X, and then you're on your father's insurance, and he gets a promotion, new job, but now they have a different company. Mm-hmm. Then they switch, and they forget to tell you that they switch. And then all of a sudden you put the prescription in and it's not going through. And they're like down, and they're down to the last pill, because why isn't it going through? Because your new insurance is requiring a prior authorization of that medication. And it didn't matter that you were already on it, because this insurance is a different one. And that's a huge sometimes problem and that's where also I like the objective testing, because it speeds up that, look, I've already done it. I'm going to just give it back. And so, and that happens a lot. And I try to tell my please keep us updated, because when and if you change insurance, there could be, and we don't want to wait till you're on your last pill. Let's be proactive about it. But people are busy, and sometimes, they forget, you forget, and job changes quickly. And then sometimes they're stuck with having to pay out of pocket for a month. And that could be pretty tough for them too.
Yeah, no, absolutely.
With regard to QB test, one of the things that it's really helpful in making an objective diagnosis, but to get the objective feedback on the back end of symptom control. And one of the things that I find is most helpful when you have those two tests together, and the parents can see the result of that very busy movement parameter going down to size, and they can see that they're not missing as many of their targets, and they can see that the time to response is improved. It really helps them, I think, understand how important the medicine is, and that this is actually a neurological, that network that we talk about for focus that keeps the smart kid brain online so that it can get things done is connected, and we can demonstrate that with objective testing.
And do you find that when you're able to show them that visual quantitative representation of their child's progress, or their own progress depending on the patient, right?
Exactly. I think it really answers a lot of questions for them, because the symptoms of ADHD are not neurological, they're behavioral. And so having those cardinal parameters that are measured by QB test and seeing the improvement or not, right?
Right.
I'll tell the story of the child who was treated with multiple psychotropic medications over a 2-year period, had to go to a special school for behavioral issues. 4 or 5 different psychotropic medications, while the ADHD medicine stayed exactly the same. It was never increased or changed. But the child's mood and anxiety continued to spiral out of control. but it was because of untreated ADHD. So when we did the QB test on 36 milligrams of the medicine he was on and compared it to when he was not on medication, they were exactly the same. They looked like untreated ADHD. Wow. We double to the highest FDA approved dose of that medication. The QB test stayed exactly the same. But we changed classes of stimulant from methylphenidate to amphetamine. It could have been the other way around, but in this particular case. And with the titration from 20 to 40 milligrams, the QB test normalized. And you know what happened at school?
It started doing better.
Much better. Citizen of the year, month or whatever within 3 months of that.
Oh, excellent.
We were able to wean and stop all the psychotropic medications.
Wow.
So if the providers that were caring, these were good people that were taking care of him, and they were treating the symptoms he was presenting with. So no one was doing anything wrong.
Right.
It was just the wrong. It was just that we didn't have the ADHD under control and nobody noticed.
They just couldn't get to the source of
They didn't get to the source of the problem. So that is, I would say, one of my most compelling, or if not the most compelling story of how important objective testing can be.
So looking at changes in symptoms, right? Sometimes it is hard to quantify subjectively, right? You ask how your day is today, how are you feeling right now versus tomorrow. Not a whole lot of change in terms of your treatment time span, but end of the day, you're really tired. If you're filling out a survey, there's going to be some bias there, right? So we wrote a paper earlier in 2024 looking at our Qbtech data, using it as a medication management. And so is there a treatment effect? Can Qbtech pick up treatment effects? And so we looked at the assessment given at baseline and then post-treatment, and then looking at another Qbtech assessment. And you see a beautiful treatment effect in all 5 scores in the Qbtech, as well as total symptom score. And, that's very encouraging to see, because there is a quantifiable way, like you say, to really see how a patient is responding to the medication. And is that the right type of medication? Because also looking at the data, we actually graphed out each individual patient. We looked at the percentage change from baseline to follow-up, and with their baseline score. And it wasn't always perfectly linear. So most of people got better. Not everybody got better. And not everybody got better in the same, to the same degree. So to your point, it is, like you were saying, you have to treat that individual patient. Are they on the right medication? And having objective data, I think, will really help clinicians like yourselves be able to see, okay, they're not responding at a half dose or at a double dose of this class of medication. However, if we switch him to a different class, look at his response on the QB scores. We're seeing a much better response. Let's follow this class of medication, see which dose of this class would optimize, this child, this, patient in their day-to-day life.
Right.
I definitely agree. I think it helps, where preventing from underdosing, where, and then maybe even going up too high. And the other thing is that, sometimes by the time they get to like us, they have struggled so much. And then with struggle becomes more struggle. And then maybe more behavior problems. And the parents are exhausted and the kid's exhausted. And then like you give them medication and they get better. And they're so rejoiced that things are better. Now he can just sit at the table and eat without me telling him 10 times. And they're like, I'm happy. And then but you're like, but are we really where we want to be yet? But they're so ecstatic that things are better and they want to stop. And you're like, well, okay, let's just see where we are. And then you do the test and you saw that it might have went from, the 99, whatever. And then you can say, look, there's still room for improvement. Because sometimes they're so happy with anything because everything has failed so far.
They might just stop short of the goal line.
And again, drawing the chronic disease model from primary care, my asthma is better. Well, does that mean you weren't in the ICU? You haven't had to go to the ER? Does it mean that you can? So I want the kid to be able to exercise at PE. I want the kid to be able to sleep through the night without coughing. There's some I want the symptoms in remission. I don't want them having, not just improved, but we want, and then you have to walk that careful line between optimal and then the little bit of blunting or losing their spark.
Right.
And I think clinicians like David and me are on the look out for that all the time, because we don't want to change in personality. It's not necessary to have optimal ADHD symptom control. You shouldn't have to medicate your child in treating the ADHD.
Right.
You're treating a medical condition. You're not medicating the child. And so another way that objective testing, and I think this is so reassuring to parents when we have this conversation, is that if the child goes from, as David was saying, the 99th percentile, and the movement parameters and the attention parameters are way out, and then they come back on a dose of medicine, and all of a sudden the response time is like a robotic zombie did it, and the movement has gone from all over the little cross on the testing to pinpoint, then at least it cues me to say, whoa, is this too much? It doesn't say it's too much medication, but it definitely makes me put a pin in it and say, let's be double sure. Let's double check with the teacher. Let's check it on Saturday at 10 o'clock in the morning as the medicine's peaking, because sometimes 2 or 3 hours of blunting may be overlooked. And that's when we tend to do our repeat testing, right, is at the peak of medication effect.
Yeah. And I think that's really a good point that you bring up, because clinicians like yourselves, it's really good that you are so proactive about getting to the right level without just shooting over and saying, well, it's fine,
Right.
And to be able to see that in a very measurable way, using objective data and saying, well, I think there's been an overcorrection potentially. Mm-hmm. So let's reevaluate. Let's maybe recalibrate a little bit and see if we can find a little bit more of an optimal zone.
And sometimes kids and young people who have struggled with ADHD symptoms for so long are a little bit high on their dose, and they're feeling that. Mm-hmm. But I had a patient last week who didn't want me to decrease the medicine because of fear that the ADHD symptoms would come back and her performance would drop. This is a perfectionistic little girl, as you all often are. And she did not want to take a chance. And I said, listen, you don't have to be quiet at lunch to do well in math, right? You should be able to, when it's time to do math, do math.
Yeah.
We're not trying to use the medicine to regulate your behavior. We're using the medicine to connect the network so that you can self-regulate the behavior. And that's modern ADHD therapy, as opposed to when I was a young pediatrician, the goal was to calm mostly little boys down.
Right.
And we didn't think of that as creating the zombie effect, but we must have known, right? Because we recommended medication holidays.
Yes.
Which are not a part of modern ADHD therapy, in my view, because the symptom control needs to be very regular, and symptoms are affecting, whether we acknowledge it or not, the symptoms are affecting home life.
And also a little bit, it should be a little bit more predictable too. I would imagine as a patient taking ADHD medicine and then suddenly 2 days out of the week you're not, and you're feeling so dysregulated. And I feel like that'd be very confusing, for the patient.
And some people do poorly. I mean, I drink coffee every day. And if I don't drink coffee, I am irritable and I get a headache. And because I am, I rely on that bit of caffeine in the morning. And I say that can happen, sometime with stimulants. Like, and the stopping and starting could be pretty unproductive. And again, you give them education and you work with them. Yeah. And as I say, this is not like a school problem. This is like a life problem, and it's going to impact the relationships, your guys' relationships, your and the husband and wife relationship, the parent-child relationship, and the romantic relationships later on in life. And I say this, how they drive, Do they impulsively?
That's a huge one, driving.
Yeah. Do they impulsively buy things when they really can't afford? I mean, this is like, we're helping you, yes, perform in the area that you're asked most likely to perform, but we want you to be able to regulate and think about things and put the brakes on, so you can then, not sometimes make mistakes that sometimes are hard to come back from.
Yeah.
Stopping and starting medicine also can affect mood regulation. Often, especially in pediatrics, parents will feel like, well, we need to give him a break so he can eat more. And then they notice that when they stop the medicine, the appetite is really sort of supercharged. And I always point out that that's not necessarily a good thing. So the more the medicine is stopped and started, the more the appetite thermostat is reset. And so it tends to prolong the waning of the side effect of appetite suppression to stop and start the medication.
No, interesting.
So my corny little rhyme is, take your medicine every day and the side effects should go away. If they don't go away over time, or they're not manageable over time, then you need to have somebody who helps you manage the side effect rather than avoiding the medication. Yeah.
Okay. So with, like, you're talking about the kind of more modern approach, right, in ADHD treatment, what other advancements do you see that might be coming into the future of titration and medication management? And do you see objective measures playing a role in it?
Yeah, I mean, advancements of, you hope that they develop, better, more effective medications. I mean, it's the first time there's a stimulant you can give at night that slowly titrates, and so in the morning, they're not off the rocker until they get their medication. And so hopefully we're making better medications that are more consistent, that are different delivery systems, maybe newer classes. And I think that we're always hopeful that we're going to just keep getting better and have better treatments. And I think back to the objective measures. I mean, there's so many times where, when they see it, where God, whether it's an adult for the first time and as a validation, like, I've been struggling my whole life. I felt like I've had to work harder than everybody else just to tread water and keep up. And this now validates it. And now they're excited. And again, I have it sometimes where you do the objective measure on the kid, and the parents are so blown away by that and the information you give them in that visual. Next, the next kids come in and they're like, and then the husband, and then they all question, like, maybe we all thought we had it. And a lot of times everyone has it.
Well, it's, I think it's still, so many people don't know that this condition is more genetic than asthma. It's more heritable than asthma. And everybody acknowledges that allergies run in families, right? So, but it is more heritable than asthma. So it's not uncommon. And, some people say opposites attract. In some cases, birds of a feather flock together. And so mom and dad might both have it.
Right.
And sometimes it's validating to say, like they don't have it. It's like, listen, that's not your issue. So then we have to shift gears. Like, let's rule it out. And ruling out is, again, one of the most important things we do, is to make sure that you don't have it, and you don't have this, and we're not going to treat it, and we can figure out better ways to help whatever their goals are. And I think because people, a little bit of knowledge. Like, how many times in a relationship I hear, like, my girlfriend says I have ADHD because I never pay attention to her. I want to get tested. Okay, it's good you tested. We do our thing. You don't have it. Then maybe there's another solution to your guys' problem. And I think, but you get that in married couples too. So sometimes it's like you said, I have a low suspicion, but this is something we can do to make sure
to really help. And having normal objective testing doesn't say with certainty that it's not there. But in my experience, it causes me, again, to put a hard stop and a pin into, and then go down to criterion E in the diagnostic criteria and say, what else could be going on? And so every kid with a learning disability, for the most part, is going to have problems with attention in the classroom.
Right.
So if you're a third grade student and really you're at the crunch time for learning to read and making sure that your reading fundamentals are, established, and there's a lot of that going on in the classroom, and you have dyslexia, and you just can't do that. My experience is that kids will either class clown, shut down, or meltdown, one of those three. And all of those outcomes lead to suspicion of ADHD because disruptive behavior or oppositional behavior and that emotional response, but it may not be coming from ADHD. So the dyslexic child will have a perfectly normal QB test because it's not language-based.
Right.
Whereas any of the other testing that is used, psychological educational testing, which in my opinion should not be used for the diagnosis of ADHD as a general rule, because I don't have to have an IQ or learning disability test to rule out ADHD. It's not language-based. So the kid with dyslexia that doesn't have ADHD is going to do fine on a QB test. And we have definitely stopped medication and then asked the parents to reevaluate what was the effect of the stimulant. And so often the parents come back and say, well, the teacher says she's much more engaged.
And I think it helps because, there's a lot of overlap. And I said one of the, probably as a very common question for like school-age kids, is this anxiety or ADHD? Because it looks a lot alike. I mean, if you're anxious, you're kind of head on a swivel. You're kind of the hypervigilant. You're hard to sit still. You're doing threat assessment. You're really not focusing on what the teacher is. And having obviously good clinical interview, get collateral information, listen to everyone how they describe things, and then having an objective measure that can say, hey, look at this. Like I know you can. You scored perfectly in all these different things. Like it helps sometimes determine whether or not it's a mood or anxiety disorder. And we need more of this, and this is one of the few things where I can do a test, help. Again, it's not the ultimate in the diagnostic, but it helps me. And then I could do treatment and I could actually show you that it's better. And I always joke, so my father's an orthopedic surgeon. And I said, Dad, you had it easy. You took a picture, told him it's broken. You take a picture, tell him it's healed. You have that, and we're still working on that. But these are the things that I think are going to be the advancements and things like this, because we need better ways of doing it. Because screening tools and assessments are just that, and we need better objective measures.
And measure, hopefully with technology, the improvement in technology, we can measure some of these same parameters in the real world environment. Because it's one thing to pay attention in our clinic in a room that's dedicated to do the testing, right? It's another thing to really assess in the real world.
Well, I'm glad you mentioned that because, so the paper I commented about that we wrote earlier, looking at our Qbtech data, that was actually done remotely.
Right.
So all of the Qbtech assessments were done remotely, both baseline and post-treatment follow-up. And so that's also looking at them taking responsibility, doing it in their own home, in their own setting and not in a clinic setting, and being able to assess their progress,
Because that's where life is lived, right?
Exactly.
In their environment.
Yeah.
I've always said it's a little bit like, so as helpful as it is, doing it in the clinic is a little bit like getting the blood sugar normal in the hospital, but the kid's going to go home and have a different environment in terms of exercise and diet. It's not going to be a prescribed hospital diet and no activity. And so it can be a really great measure, but it would be better. One of the advancements I think was like Qbtech.
And looking at, Qbtech and other, potential remote treatment monitoring tools, I think will just continue to strengthen your arsenal of tools to use for making a more confident and accurate diagnosis, right? It's like putting together furniture. You can do it with a screwdriver and, put some elbow grease in and you got it, or you can use an electric drill.
Right.
And feel a little bit more confident about sitting down in that chair.
Right.
Right. But that does get me excited to think about the potential advancements, remote testing, to be able to monitor, patients' progress, adherence, compliance.
Well, it's the way medicine in general is going, right?
Yeah.
I mean, whether you're looking at technology to improve healthcare outcomes, is something that's happening across the board.
Yeah.
And again, it's about making it easier and faster. Like I wish that every kid could get a comprehensive neuropsychological assessment. We would learn a lot about how their brain works, how they react to things emotionally, socially. It's great. Those are valuable tests. They are done by very highly trained and few and far between people. They take time because it's hours of tests, and then there's a write-up. And, it makes it hard because you would love for that, and it would help us so much, but it's hard to wait for all that time where, with a good clinical interview, a more focused question, and something you can do in your office in 20 minutes, that's what, we have that. And neuropsych will always have a place, and
absolutely.
I'm a big fan of it. And there are times where after I do my assessment, I think I need to send you to for that kind of testing.
And I agree with David 100% on that, because it sounded like I was saying that was not necessary. It certainly is necessary very often, but it's not necessary to get at an ADHD diagnosis. It's more necessary to find out what's tagging along with the ADHD, if anything.
Right.
Yeah. The underlying learning disabilities
or other neurological things that tag along with ADHD. So the insight that testing provides is wonderful. But again, if you do that testing with the ADHD dose optimized, you see it through a different lens, right? Yeah. So very often when the testing is done before dose optimization, what you're seeing is the impact of ADHD on, for example, on the intelligence testing, processing speed and working memory. And so you're not getting a true picture of the child's ability because the ADHD is driving those parameters down. Yeah. And so you can't do a pre and post neuropsych evaluation, and you can't. They're really, as David said, they're not resources to do the first one. Yeah. You certainly can't go back 6 or 8 months later or 5 months later when the child's
a few weeks later,
or even in a lot of cases it can be a few weeks later. Yeah. But I can perform a QB test that's going to give me age and gender norms as well as compare to the to that particular child or adult's baseline.
Right, and I think it's a really good starting point, like you said, too. There's such a Venn diagram, right, of overlapping disorders in this category, and if we can either rule in or rule out, one fairly confidently, right, or at least give you a clearer picture or direction of which circles you can veer away from, right?
Right.
I think would, like to your point, save on time and resources, which are limited at all levels here of the process. And cost.
Cost is a huge variable.
Absolutely. So I really appreciate your time today, talking with me and joining us to discuss, titration and medication management. And anything else you'd like to add before we wrap up?
Well, I think one of the things that we hear in clinic from folks that have been treated elsewhere is we've tried everything. And the parent really does feel as though they've tried everything. Would you agree, Dave? I mean, they really do. And what they've tried is 3 medicines all in the same class at low dose. Or they've tried 3 doses of one medication. And so I would just like to end by saying there's hope out there. Don't give up. The success for ADHD treatment when medication is titrated appropriately, and by success, I mean really good symptom control, having the network well connected for focus, is really attainable with minimal side effects almost all the time. And so if you haven't gotten there, don't give up. It can be, as David pointed out, it can be a frustrating process. People call it trial and error. I like to call it trial and learning. So with each medication trial and each dose increase or decrease, we're learning something about that child's neurology and metabolism for the medication. Yeah. And as long as we're getting closer to the goal of optimal treatment, then that is time well spent, in my view. And sometimes it's easy, and we love those patients.
Right.
Yeah, and again, sometimes, I say you start low and go slow, but slow is relative, and too slow is a motivation killer. I mean, if, for example, you start them on a low dose and it's not effective, and for some reason, it's been a few weeks and nothing, maybe the kid starts giving up on it and the parent gives up on it. And yet if they see the results faster, that's definitely great. And then, you know, I think the other flip side is sometimes people are, you know, too aggressive, and they have their thing where like, I'm going to get every kid up to 50 milligrams of my favorite medication because that's where we see the average effective dose. And then, you know, then that also leads to things. And again, back to you, I so often get that from parents, and I say, can you get me their pharmacy records? And I've seen that they've been on a little of a lot, not a lot of anything. And again, there was no sort of adequate follow-up or play. And again, there could be a lot of factors to that, but you know, I think, you know, keeping people motivated, sometimes them seeing the data themselves, seeing where they change, how they've changed, how they've improved, you know, that can be a very powerful thing for some people because it's a visual that you can give them saying, you went from the 99th to now you're testing normal. Like, that's awesome.
I was thinking back to clinic last week, and the number of times I hear a parent say, "Oh, wow," after looking at the comparison test, you know, it's like it just hits them because you can really see in between the two the difference. And if they understand what the test is measuring, which they can understand pretty quickly. Very often it's so apparent, and it's really rewarding to hear them gain that understanding.
Yeah, that's wonderful. Well, thank you both so much.
Thank you for the opportunity to talk about this.
Definitely.
Thank you.